Okay, can you hear me? My name is Allan Abramovitch, and I've known Blair for many years. We've worked together on committees. We won't go into the number of years. I thank you for the opportunity to present my concerns to of the recent proposed surgical model for the Birchmount site of the Scarborough Hospital. I have been a staff urologist at the Scarborough Grace Hospital since its inception in 1985, and I have been chief of surgery for the Birchmount site of Scarborough Hospital for 10 years up until 2009. And I have seen I observe, okay, let me just go on here. And as you can see, Scarborough makes up a prominent part of the Greater Toronto Area. As you've already been informed, the population of Scarborough is fairly extensive, 650,000 people, with a rich diversity of people and a very high concentration of immigrants. As most of you are already aware, Hamilton, with a population of 490,000, has 3 full-service adult emergency departments. And in addition, there is an emergency department specifically for children. Ottawa has 774,000 population, and they have 4 full-service emergency departments, and including a hospital specifically for children, the Children's Hospital of Eastern Ontario. And Scarborough, with 650,000 people, has up to now 3 full-service emergency departments, which also serves pediatrics. And I understand about 25 to 30% of the visits to the emergency department are made up of pediatrics, a pediatric age group. So that certainly Scarborough does need and does deserve 3 full-service emergency departments. I also want to point out that the annual growth that I have observed the population increase around the Birchmount corridor since 1985. The Census Canada data has indicated a 3% annual growth in North Scarborough versus a 1% growth in South Scarborough, similar to Toronto overall. And this is just a reminder that the Birchmount Campus Hospital initially opened as a Salvation Army Hospital in 1985, merged with the general site in 1989-1999. That the combined budget for the Scarborough Hospital is $350 million, with 550 beds in total, of which 227 beds are at Birchmount, of which 50 beds are just mental health. Now, I've always maintained that the best measure of the need of a hospital in a community are the number of emergency visits. The activity of a hospital can always be modified by bringing on additional programs, certain physicians or physician groups, but that the number of emergency visits is the best measure of the need of a community, need of a hospital in a particular community. As such, then, as you've already been told, the number of visits at the Birchmount site is 48,000 at this time. The general site, 64,000. This is in the year 2010-2011. And Rouge Valley, the 3rd hospital in Scarborough, is 55,000. In 2003, the number of visits at Birchmount site was 35,000, and this is a 35% increase in the number of visits in the last 10 years. Again, approximately 3% per year, as I've alluded to in the previous slide. And as I believe you've already been informed, there are numerous condominiums and buildings going up and geriatric facilities that are planned for the North Scarborough area. So I do not believe that this 3% growth, annual growth, will decrease anytime in the near future. The recent proposal, as a result of the Hay Group investigation, has indicated that that there should be certain program transfers, that all outpatient surgery and ENT surgery should take place at the Birchmount site, and at the general site, all major surgery, fractures, surgical clinics, inpatient surgery would take place at the general site, and that the only surgical ward at the Birchmount site would basically be closed with only 5 beds planned. The administration has also indicated that they would advise the ambulance service to bypass the Birchmount site and go to other emergency departments if they felt a patient required surgery. This, I believe, is untenable. The Hay Group also noted that there was a 75% occupancy of 3 surgical wards at the general site of approximately 100 beds. There's a 75% occupancy of the 1 surgery ward at the Birchmount site, of which are 30 beds, and they recommended that 20 to 30 beds be closed. I could not understand why the recommendation of the administration would be to close the only Birchmount surgery ward if the intent was to maintain a 24/7 emergency department. If an inpatient surgery ward is vital for a hospital with a busy emergency department, if sick patients with a significant possibility of requiring surgery need a period of observation or they need immediate surgery, and a surgical bed is usually required immediately. Often sick patients are admitted to the medical service or to the ICU, and these patients also need to be, if surgery is to take place, again, these patients need to be admitted to the surgery ward. And also, if there's an extensive number of outpatient procedures being performed in the operating rooms, a certain percentage due to various concerns would have to be admitted for observation to a surgery ward. Also, if emergency surgery were to take place at the Birchmount site, there needs to be a certain familiarity of the nurses and various paramedical or OR personnel with these kinds of procedures. There needs to be a certain amount of operating room equipment to manage these complex cases that come to the operating room on an emergency basis. Therefore, there needs to be a minimum amount of surgical equipment and a minimum amount of nursing expertise in managing some kind of complex cases so that emergency surgery taking place after hours can be managed safely. I believe that centers of excellence and operating resources should be distributed across the 2 sites and should be balanced across the 2 sites to maintain 2 24/7 emergency departments. Up to this time, it has been the intent of the administration to sacrifice the emergency care at the North Campus in order to maintain centers of excellence. I believe that emergency care should not be sacrificed and is not necessary to maintain centers of excellence. What would be the outcome of that proposed surgical model? Well, if there is no after-hours surgery taking place at the Birchmount site, then there would be significant delays. Sorry, there would be significant delays in these patients being transferred to the general site and receiving the emergency surgery. There would be a significant ambulance run, again with delays of 2 to 4 hours, and these patients reach the other site. And where would the liability be? And a greater concern is that as the community discovers that the sick patients are not being managed at the Birchmount site, they're going to lose confidence in these patients being managed at the Birchmount site, and the number of visits and the kinds of patients presenting to the Birchmount site will dwindle, and there will become an urgent care center. And also patients then would bypass the Birchmount Emergency Department and go to North York and Markham. There would end up being a big black hole in North Scarborough for emergency care. And there would be a significant dwindling of hospital resources at the Birchmount site. What are the solutions? I believe that there should be a reduction in administrative expenses at the Scarborough Hospital. In 2010-2011, the percentage of the budget for administrative expenses was 7.27%, whereas the mean in Ontario is 5.75%. If administrative expenses were reduced to the Ontario mean by 1.5%, there would be an annual saving of 5.25 million annually. Also, there can be a reduction in inefficiencies, and there are certain surgery divisions that just have too many surgeons. Therefore, in summary, Scarborough needs 3 strong hospitals with 3 full-service emergency departments. The closure of surgery beds at the Birchmount site, the elimination of after-hours emergency surgery, and elimination of all complex surgery at the Birchmount site will lead to delays in emergency surgery and will lead to poorer surgical outcomes. The community would then lose confidence in the Birchmount site managing sick patients, and the Birchmount site will become an urgent care center. thank you for your attention, and I'm open for any questions.
Questions for Dr. Brown? With respect to your surgical services, is it all surgical services that you want represented at both sites, or is there a core group of surgical services that you feel need to be at both sites?
Well, I think there should be a certain a certain complexity of emergency cases, sorry, not emergency, just certain complexity of surgery cases that should take place at the Birchmount site so that appropriate equipment will be there. There'll be nursing expertise to manage these complex surgical cases so that when emergency surgery is required, there will be familiarity of the nurses in managing these kinds of patients and the equipment will be present. The exact distribution or how these the exact divisions and the kinds of surgery that should take place at both sites, I can't say at this point. I haven't been part of the, I haven't seen the data myself, and but I'm sure it could be performed. I've seen this kind of data before, and I think it can be managed. Well, I think at one of the sites there's been, over the years, there have been certain surgeons retiring, and then certain surgeons are then brought on to replace them. Sorry, they're not retiring, they stop taking call. And then as they bring on new surgeons who then sort of start taking call, and then as they're around, they start taking, then they start getting operating room time. And this has developed over the years. So there are certain divisions that have a fairly extensive number of surgeons, and many of these surgeons who are not taking call actually get OR time. And I know that certain hospitals have a policy that if you don't take call, you don't get operating room time. So I believe that there are certain divisions that have a large number of surgeons on staff, all having regular operating room time.
Can I just take that one step further as I start with my question too? So, if there were a reduction in the number of surgeons, would you anticipate then that there would be less operating time overall, or would it not be swallowed up by surgeons that are quite experts?
Well, I mean, I think that one should, if one were, I mean, if I were asked to how would I would implement such a reduction, first, at the present time, all divisions are being asked to reduce their operating time, including surgeons who are doing cancer surgery. So this is going to lead to a longer waiting list for certainly urology patients requiring cancer surgery, which I don't think is the right situation. I think one should look at what would be the right component or number of FTE surgeons with any particular division at the Scarborough Hospital, and look at other similar hospitals in the Greater Toronto area, or perhaps even outside. Look at what is the number of plastic surgeons, what's the number of urologists, what's the number of orthopedic surgeons, what's the number of ENT surgeons, and then how many are at the Scarborough Hospital. And if there are more, and I think some of the divisions are, then the number of ORs to that particular division should be reduced. And it shouldn't be across the board. There are certain divisions that have the right number or even less surgeons than are required to meet the needs of the community, and they're being reduced as well with the recent proposal.
More comments on the south of the board that has demonstrated that there's variations in the number of surgeries on which are necessary.
Well, I think south of the border, the way medicine is practiced is very different than here.
Just one quick question. You said that you're the chief of surgery at the Birchmount site.
I was.
You were?
I were. Not anymore. Until 2009.
Who's the overall chief of surgery? Is there an overall chief that covers both sites? Or
Yes, 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 no. Well, there's one, well, at the present time, there's one chief of surgery, the program director for surgery, and then Mike Chapman. And then he has assigned chiefs of divisions who are then responsible for the two sites. And I think, and at certain times he assigns a certain member of the Birchmount site to act as chief in his absence when he's not present.
Just a little bit about myself. I'm the interim chief and the medical director of the emergency department. I've been in that role for 9 months. And previous to that, I was the deputy chief of the emergency department here at the Scarborough Hospital for 7 years. And I've been an emergency physician for 15 years. Just a little bit more about our department. We have two 24/7 EDs at the Scarborough Hospital. Annual patient volumes, 47,000 visits at the Birchmount, 63,000 at the General. And there's 60 hours of coverage at the Birchmount site and 80 hours of physician coverage at the General site. So lots of physician coverage, double, triple, quadruple coverage at peak times. And we have 50 emergency physicians on staff, 35 full-time equivalents. And let's just give some background. So about the emergency staffing, we're actually staffed by the Scarborough Emergency Department Associates. So that's an unincorporated group, physician group. And there's one governance agreement between all the physicians. We're not cited. In fact, virtually all the physicians work at both sites. So, and there's this governance agreement governs our relationship with each other, physicians, and also between the hospital and the Ministry of Health. And we have an accountability agreement that we will staff the emergency departments. The accountability is not with the chief or the hospital. It's actually, it's a tripartite agreement, so that each individual physician has an accountability to staff the departments. And we're virtually all FRCPC, Royal College, or CCFPEM certified emergentologists. We have a few family doctors left in our department who do shifts there. And as I mentioned before, we all work at both sites, save for a few of the older docs who have been grandfathered. And so the ED physicians, and I represent them because not only as their chief, but I'm also the medical director of the Scarborough Hospital ED Associates. So that's separate from my role as the administrative chief at the hospital. I'm also their medical director of their group, their unincorporated, sort of business group, if you want to call it that. And we support two 24/7 emergency departments. And we will provide the services irrespective of the siting of any of the consolidated programs.
Can I ask you one quick
Yes.
question? Sorry to interrupt.
Yes.
When you say you're medical director of the group, that doesn't mean that you're a medical director like a program director?
I'm also a medical director at
So
TSH.
you are both the chief and also operational.
For the Scarborough Hospital, but the physicians have their own business group. There's a business manager and a medical director of that group. So it's a separate entity, but yeah, I'm in two roles, two hats. Right, well, three roles, yes. So yeah, the group, the ED Associates of Scarborough, yeah, hope so. Will be providing emergency services regardless of citing of any consolidated programs. No one's said they won't work if there's not X, Y, and Z, or they won't work because this is happening. The group will provide emergency services to our community, full stop. Emergency doctors, our capabilities, we pride ourselves in providing, resuscitation and stabilization of critically ill patients. I think we're here mostly because, to assess any risks associated with these plans, the strategic plan refresh. And so, we're capable as skilled emergency physicians and properly credentialed emergency physicians of providing advanced airway management and vascular access. So any sick patients that come in the emergency department, it's actually, for us, emergency physicians, it's actually easy. It's very algorithmic, based on algorithms and based on your ABCs. You secure the airway, and we're all trained in that. And with the video laryngoscope, it's fairly easy and successful. And now, with the easy IO, intraosseous access, that's essentially supplanted, central line access for getting quick access for for your drugs and fluids. So, we're very capable of resuscitating and stabilizing critically ill patients. That's not an issue for us. And so right now we have lots of access to all our specialty care. There's a list. I can't even fit all of them on the list. And I think with the strategic plan refresh, the specialties that are affected are general surgery, obstetrics and gynecology, and pediatrics. So I'll address each of those. Not psychiatry, sorry, I don't know why that came up. But so with respect to general surgery, in the strategic plan refresh, in the communique that came out, the plan will ensure that the Birchmount campus will be capable of providing emergency general surgery. So, as an emergency physician, I have to take that, at face value, that they're going to work out a plan that they will be providing emergency general surgery. So I have access to that for my patients that come in. Anybody that has a, ruptured viscus, appendix, and so forth. That will be on site at the Birchmount. That's what it says in the plan, and I have no reason to believe that won't be done. With respect to gynecology, yes, the maternal newborn program will be at the Birchmount site, but the plan doesn't actually, strategic plan doesn't preclude having access to gynecological consultation at both sites. So that secures access to my gynecological, for my gynecological patients and emergencies, such as ectopic pregnancy, torsion of the ovary, some bad vaginal bleeds. There are GTA hospitals with high volume EDs that don't have on-site inpatient gynecology services, yet they still serve those patients. They have access for those patients. So I think our standard, our plan for gynecological care will be as good or better than these other EDs that don't have inpatient gynecological service. We'll have access for them. Okay? And the emergency department will work with the Department of Obstetrics and Gynecology to ensure that our patients are safe and that they have access, the patients have access to their services. And finally, with pediatrics, the strategic plan refresh had provision for, and I quote this, for delivering the program at both sites. There are GTA hospitals with high volume EDs, again, that do not have inpatient pediatric beds or even on-site pediatrician. And I think our plan, the standard for us going forward will be as good or even better than these other high volume emergency departments in Toronto. And the ED will, again, work with our partners in pediatrics to ensure this access for patients, and how this access, how this will be provided, that will be part of sort of, planning, implementation, and execution. But, I think we can, get access for our sick children. And that's it. That's all I have.
Thank you very much. Questions?
Yes.
Have the group looked at any point or considered or thought about any other rejigging of emergency departments across the Scarborough area? And by this I would say either fewer emergency departments or some combination with urgent care services or even, for that matter, proposals for more emergency departments. Is that entered into the group's discussion?
The group has not formally discussed those ideas. There have been sort of talk about whether we need 3 emergency departments in Scarborough. The fact of the matter is, they're very high volume emergency departments, each seeing 50,000, 65,000, and at Centenary, I think 55,000 patients a year. So they're high volume. Our group, the emergency physicians, are prepared to provide emergency services. I don't know if it's going to be coming to Canada, but in the United States, freestanding emergency departments are one of the fastest growing areas of care. And if you look at, really what we do, we stabilize and we resuscitate patients. And after that, we just need access. Do they need to be at the same site? Maybe not, because, for example, we don't have interventional cardiology for our patients. When they come in with chest pain and a STEMI, acute myocardial infarction, they get very good care. In fact, if I had chest pain, I would go to my hospital, because the door-to-balloon times coming from my hospital are as good, or in some months even better, than the door-to-balloon times coming from the PCI center. I have those statistics. We analyze them every month. And that's because we have a process in place. You know, we identify, we resuscitate, and we transport the patients. In the United States, one of the arguments is, well, when you transport the patient, really, it's just like a horizontal elevator ride. So, you know, yeah, it's been proven to be very safe. And I don't know of any freestanding emergency departments in Canada, but certainly I believe our emergency department is capable of providing, you know, safe care. And I don't see us closing, or none of the emergency doctors, you know, think that would be, you know, prudent at this stage, given the high volumes and without alternative access.
So I'm going to ask you a question.
Yes.
That's probably a little bit off on things. When you think of the Scarborough Hospital, if you were going to brand the Scarborough Hospital,
Yes.
what are the things that stand out in your mind is what is it that we actually offer Scarborough as a community?
Well, I would like to say that we offer comprehensive services, access to comprehensive services, and we provide, you know, culturally sensitive care. We're good at that. You know, it's an immigrant population here. We have physicians that are engaged in that aspect of the care, and you know, with respect to language issues and cultural issues. So I would brand us as you know, providing very good culturally sensitive care and care in a timely fashion. We, at one of the sites, we provide in terms of the ED performance, in terms of length of stay, physician initial assessment, all those 5 metrics that we get money for. In the P4R program, the Birchmount campus is actually one of the top performing emergency departments in the GTA. In fact, not last year, but the year before was number 1 or number 2 in Toronto. This year, maybe it's still in the top 3, I believe, comparing to our peers. And that's because, you know, we're committed to providing timely care to our patients, and with the other site as well, you know, we've been improving every year, every month, in fact.
So just to follow up, a number of the slides you refer back to the strategic refresh and the availability of certain services. How would it change the view of your group if some of those groups, whether it's pediatrics, anesthesia, OB/GYN, said that in fact they couldn't provide coverage and provide access at one of the full service sites?
Well, you know, I'm not the Department of Pediatrics, and I'm not the Department of OB/GYN. I'm not going to tell them how to run their department. I have some ideas that I can help them with. You know, it's a question of whether they can't or they won't. It's done at other hospitals. You know, as I said, you know, we have other hospitals in Toronto that, for example, Sunnybrook doesn't have inpatient pediatrics whatsoever. Doesn't have a pediatrician on call. They don't have a sign saying we don't see children. They see children, and they're very capable of resuscitating and treating children. That's at Sunnybrook. That's at St. Mike's. That's at, you know, a whole bunch of other hospitals in Toronto. So as I said before, I think our standard will be at least as good, if not better. You know, so the worst case scenario, okay, whether they can't or won't, you know, we can still get access for the care. I think the emergency physicians will be able to, you know, stabilize and resuscitate and provide access.
My question is actually fairly similar, but we heard today from a number of different specialists who felt that a model where there was an emergency department without immediate access to backup specialists, for example, general surgery, would be untenable and unsafe, which what you're describing is somewhat different. If you said about the model in the US and then the possibility of stabilization of a ruptured viscus was one of the answers, the examples, and then stabilizing and then transferring 10K to the general site of surgeries there. Is that viable?
Well, again, I mean, I think perhaps we're thinking, a couple of steps ahead of ourselves. I mean, the plan does say that that emergency services will be provided at the Birchmount site. If they can't, again, we'll have to look at models out there where it has been successfully implemented.
Do you mean when you say emergency services, you mean the backup services?
Yeah, it says that when ensuring that the Birchmount campus is capable of providing emergency general surgery. I don't know exactly, in terms of the planning, but I think that's, they're going to provide on-site general surgery, emergency surgery backup, as I understand. But the code STEMI analogy, those are the sickest patients. Those are, their heart can stop, they can run to arrhythmia, and we transfer them fairly successfully. If we can do it with very sick patients, can we do it with other patients that are, just as sick? I don't know, but I think other hospitals have tried that, and perhaps, we have to look into that further. But as the plan stands, right now it says there's access to general surgery.
Any other questions?
I
Yes.
wanted to know, in your opinion, around the image that the Scarborough Birchmount site has for the community in terms of recent deaths of two young women, as well as other things that we're hearing today. I wondered, what would you do as a doctor who is supportive of the hospital? What are some of your
Well,
ideas?
As an emergency physician, as I said, I gave some statistics. We're already providing very good care in terms of our performance. I think there perhaps has been some sensationalism in the past. Deaths could be, sort of high profile. And I think there has been reviews in the past, and I don't think these deaths were sort of, out of the norm. But I agree. There has to be some work to be done with the branding of the hospital, and I think we have to focus on the positive aspects of our hospital, and not always, look at the negatives.
Thank you very much.
Okay, thank you.
Yes, my name is Pat Sherman. I've been a resident of Scarborough for the last 37 years. Maureen Coram is also a member of our community for a similar number of years. The Friends of the Scarborough Hospital are a local group of residents and community members with concerns for the quality of health care over the entirety of Scarborough, including 24/7 emergency acute care services at both Birchmount and the general campuses. From our understanding, Central East LHIN priorities are developing patient-centered care as a priority for LHINs across the province. According to the Central East LHIN, service and system integration is one of their strategic directions. According to their website, the Central East LHIN is working to create an integrated system of care that is easily accessed, sustainable, and achieves good outcomes. And that, as an organization, the CELN will engage the community to identify opportunities to enhance their healthcare experience. And that has been our experience with the Central East LHIN. Scarborough's demographics have changed a lot in the last 40 years. Scarborough demographics, we feel, demand a two-site TSH hospital system. The population of the GTA is forecast to grow by approximately 1 million people over the next 10 years. And Scarborough is approximately 26 to 27% of the GTA. So it's not hard to conclude that Scarborough will be approaching a population of somewhere around 1 million people by 2022.
And only one has to look north to Highway 7 to draw the conclusion that Markham intensification is progressing exponentially as well. Drastic cuts to baseline core health services and generic approaches to care limit and fall short of Scarborough's growing population of newcomers. As far as development within Scarborough, there is a burgeoning new development that is about to explode. Ward 40 alone, which is the ward that the Birchmount campus services, has more than 5,500 units on the table. As part of its long-term service planning, the Scarborough Hospital, we feel, must research and review planned residential development in all parts of Scarborough beyond Ward 40 to ensure that the hospital is able to meet the long-term needs of our communities and not just the requirements of a knee-jerk lack of funds at the provincial level. Building an evidence-based strategy for care. This was interesting. It came out of a study done by the province of Alberta. It appears that if the Scarborough Hospital's approach to forward planning is to balance the budget, there does not appear to be much consideration on how to maintain 2 high-activity hospital sites to meet the respective needs of the community. The targeted reduction of services and outright consolidation will have long-term detrimental ramifications on the socio-economic well-being and future of Scarborough citizens. The Scarborough Hospital needs to use an evidence-based strategy for developing long-term plans for care. And this perspective that we have used is based on an Alberta healthcare experience and a paper written by Robert Gerst, Understanding and Expanding Capacity in Healthcare, written in May of 2013. Now, in our package, this is just a preface of a larger study that I wouldn't be able to present to you in 10 minutes, so really this is a synopsis. The information we've based our comments on is included in the document that we've left with you. Now, another reality in Scarborough, in terms of barriers to accessing health care, Scarborough is challenged by a lack of modern, rapid public transportation. That's well known. Transit in Scarborough was never designed for walking pedestrians. It was designed for 40, 45 years ago for people with cars. Well, the demographics of Scarborough are changing dramatically. The Scarborough, or the SRT, or the Scarborough Rapid Transit, has reached the end of its useful life. Bus services on Finch, Shepherd, and Eglinton are at overcapacity. 4 of the 10 most congested intersections in the GTA are in Scarborough. Toronto planning is showing that more and more transit demand in Scarborough is not an effort to access downtown core. Everybody seems to be, determining their decision-making process on how can we get more people downtown. Here in Scarborough, more and more of the residents rely on public transit for their daily transportation needs, especially the new immigrant community. Consolidating any services to a single site will increase the barriers to accessing acute care services by residents and will increase risk to patients. It's a very serious consideration for this part of Toronto. Now, demand for MNCC in 2 sites. Under the auspices of the Salvation Army, Grace Hospital Maternal Newborn Program, and the facility was unique in Ontario. Often classed the jewel of the crown, it was considered the gold standard and best practices model, often referenced and imitated by other hospitals in the province. Using information from the Corpus Sanchez report, commissioned by TSH, average annual births for Scarborough for the last 10 years is about 7,600 babies. And the median is between 7,500 to 7,546. So it's been consistently about 7,500 babies a year for the last 10 years. To our way of thinking, this is not an indication of a declining birth rate in Scarborough. Based on 2006 and 2011 Canadian census results, the number of women of childbearing age is increasing in Scarborough. Many are made up of newcomer communities. If you take into consideration the 46,000 women between the ages of 20 and 44 living in Toronto, wards 37, 39, 40, and 41, and the 6,000, living in Markham, Ward 8, it means that as of the 2006 census, there were approximately 52,000 women of childbearing age living in the TSH, Birchmount site catchment area. With the demographic changes that are happening in Scarborough, it is reasonable to conclude that actual birth rates in the area will rise in the next several years. More recently, there has been a decrease in the number of deliveries occurring at both sites, although TSH General Site may be showing signs of recovery. Many believe parts of the community have lost confidence in the maternity program as a result of high-profile maternal deaths at TSH. As these occurred with Chinese women, the local Chinese community is reported to be particularly apprehensive for the quality of care in TSH Birchmount site. The hospital has been ineffective in aligning community support and in mitigating concerns and addressing these relation issues with the Chinese community. It is also the community's understanding that in January of 2006, there was a proposal to consolidate OBS to the general campus, which was never implemented. So if the plan was never implemented, why in June of 2006 were 2 floors of OBS at Birchmount combined onto a single floor with patients being crowded into fewer rooms? Why the following month did the hospital endeavor to hypothetically save money by cutting the nursing staff and restricting services, i.e. closing the unit when it got too busy? This despite an increasing number of deliveries. In December of 2006, one of the C-section rooms were converted into an ophthalmology room, leaving C-section now with only 1 room. What we as a community have witnessed is a decrease in capacity at Birchmount, not a decrease in demand. As a community, we find it sad to see a once excellent program at the Birchmount, one emulated by hospitals across the province, deteriorating to its current state. In light of the Canadian census results, one would ask whether it is irresponsible planning or a decided lack of vision. Now, our other major concern is effective 24/7 acute care emergency room capability at both sites. The Birchmount campus is currently a 24/7 emergency care facility. The community's biggest concern that it is being slowly eroded to an urgent care state. We are very aware of the ongoing discussions that would see OBS-GYN consolidated, and if certain OBS doctors have their way, relocated to the general campus that would result in an outcome that is not in the best interest of the residents of the Birchmount campus catchment area. If obstetrics is moved, the justification for a 24-hour anesthetist is not there for the Birchmount. And if you don't have an anesthetist, real emergency care is not available. We are hearing that surgical services are being considered by the TSH for major changes, where complex surgery will be consolidated at the general and day surgery at the Birchmount with a closing of beds at the Birchmount site. How would this strategy support an independent, full-service, 24/7 acute care ER at the Birchmount? We've been told by the previous CEO, Mr. John Wright, that no matter what, people coming to the Birchmount ER would be treated, even if it means stabilizing and transferring to the general.
Just one thing, you have gone a little bit over. Can you?
I've got about 2 paragraphs. This process is not supported by the physicians of TSH. They feel that the risk is too high and could result in the death of a patient. The community has not been asked whether they are prepared to live with that risk, and having an expert panel rule on its efficacy is not a valid risk mitigation strategy. The whole thing starts to unravel. The outcome as far as the community is concerned is that we will end up with a glorified walk-in clinic, thanks to the overt efforts or benign neglect, take your pick, of TSH executive management. There are examples across the province of hospitals with population catchment of Northwest Scarborough running full services. We cannot say loudly enough, we protest this wanton waste and disservice to Scarborough. Perceived low-hanging fruit should never be a consideration when looking for productivity improvements. If under the new changes in healthcare funding, as TSH CEO, the TSH TSO has consistently pointed, the money follows the patient, then why are we considering a reduction in patient services that would drive people to other hospitals? A responsible TSH management should advocate recommendations that build on patient-centered priorities, that build on strengths. It should take a long, hard look at all the operations for this situation, and not just an ill-considered reaction to cut an entire program. Thank you very much for your time.
At the Grace Hospital. I was very, very shocked because I've heard nothing but negative comments about that campus. When I told my dad that we might have to go to the Grace, he actually told me the Grace is the worst because, like everybody else, he's heard that some mothers have died there, and it really concerns him. So when Dr. Tam told me that I might have to go there, I was also very scared because this is my first baby, and I'm quite nervous about going through labor. So it would be terrifying if I had to deliver at an environment which I'm not comfortable with. If I could not deliver at the Scarborough General Hospital, I would have to leave Dr. Tam and find another doctor to deliver at the Northrop General Hospital. Trust me, I really like Dr. Tam, but it's just such an important day for me, and I don't want to do it at a place where I'm not comfortable. And I don't want to go to the Grace Hospital for my neighbor. Thank you.
My name is Junyi Gao. I am a mother of 2 children. They both was born in Scarborough General Hospital. The nurse and the doctor was very professional, nice, and guided me throughout my 2 labor experience. I know most of Chinese people like to go to the Scarborough General Hospital instead of Scarborough Grace Hospital because they are afraid that another accident might happen again. And if the Scarborough General Hospital will be closing down, I know that the Chinese community will go to the Northview Hospital or to the downtown. So I'm expect my 3rd baby. And I'm going to Scarborough General Hospitals again. So please, I'm asking to not close Scarborough General Hospital. Thank you so much.
I'm a lawyer and have been practicing real estate and commercial law in Scarborough for over 33 years. I was a member of the Scarborough General Hospital Foundation Board from 1991 to 1998, a member of the Board of Governors from 1996 to 1999, and a member of the Amalgamated Board of the Scarborough Hospital from 1999 to 2006. I also served on the board of Trillium Gift of Life Network from 2004 to December of last year. In 1996, I founded the Scarborough Chinese Outreach Committee, engaging our citizens in healthcare courses. We have undertaken many community outreach activities, including the hosting of an annual Scarborough Health Fair and the Mid-Autumn Ball. My organization has raised $1.6 million to benefit the Scarborough Hospital. 8 years ago, due to a starving shortage of anesthesiologists, there were attempts to close the Birchmount ED. The hospital also considered as a cost-cutting measure the consolidation of its MNCC program to the general. Over 130 doctors at the time signed a petition urging the reversal of the decisions, stressing that obstetrics and pediatrics are the integral backbone of any 24/7 ED. Dr. Norman True, now Chief of ED, signed that petition. Dr. Tom Chen, the present Chief of Staff, who was then the emergency chief, spoke at public forums in support. As a result of a series of community protests and rallies, appeals to the Minister of Health, we succeeded in keeping both the MNCC and ED for our North Scarborough residents. It may seem that we were just fighting to save the Birchmount site then, but in fact, these were efforts to safeguard the essential health care for the Scarborough community. It has never been about Birchmount versus General versus Centenary, then or now. It has always been about what Scarborough deserves when it comes to fundamental healthcare services that must be offered by the 3 sites in reasonable satisfaction of the community needs. In 2011, Birchmount has 47,216 ED visits, General, 63,387, and Centenary, 60,104. For the 3 Scarborough hospitals, a total of over 170,000 visits per year is a huge, staggering volume. This time, over 330 members of the medical staff of the Scarborough Hospital, who serve the community day in and day out, have advised and warned the hospital board and Lynn that this SPR plans will have a serious detrimental impact on emergency services. That without on-site 24/7 support of obstetric, pediatric, and inpatient general surgery, there would be in effect no ED service. The signatory to that petition includes over 95% of all the ED doctors at both sites, of which 4 are former chiefs of the department. This is a powerful testament. Although this panel may come with impeccable academic credentials, I respectfully challenge that you all lack the one key and most important qualification: Scarborough practical experience. When over 330 of your colleagues, your peers, the frontline doctors who deliver babies, perform operations, administer urgent care, saving care, 24/7 at the Scarborough Hospital, express their professional opinion that the proposed plans are not safe, I would think that your concurrence is a foregone conclusion. To render a contradictory finding that such plans promoted by the administrators are clinically feasible, or the level of care is acceptable, is an insult to the Scarborough community. It implies an unconscionable lowering of the bar and downgrading the standard of care. To suggest that mitigation strategies will all have to do is an affront to our community. It is disrespect of our value of Scarborough residents' life and health. No one has the right to draw on, as the former CEO attempted in vain, precedents at other hospitals such as Toronto General, where there is an obstetric and pediatric service, but where there is no obstetric and pediatric service, when such essential complementary support services for ED are readily available as Mount Sinai and St. Kitts, just across the street. It is an insult to our collective intelligence. Similarly, no one has the right to reference distant hospitals with vastly different communities, as implicitly encouraged by your appointment, to recommend mitigating strategies and to determine the sufficiency of care for Scarborough. I ask this panel to differentiate. What works for one community may not work for the other. One must consider all aspects of human and social factors indigenous to Scarborough, such as diversity, high concentration of new immigrants, language barrier, socio-economic makeup, transit dependent, limited family doctor support, and few pediatricians. Understanding such local issues require first-hand experience. Hence, the doctors who are in the trenches are the experts. The medical staff, based on their years of experience serving the Scarborough, have spoken, and we respect and trust them. The government, by its Ontario Action Plan, touts right care, right time, right place. It assures its citizens that any divestment of services from hospital setting is contingent upon, firstly, that the quality of service will not be compromised, and secondly, can be provided at less cost. Contrary to the directive of the Ontario government, the goal of TSH leadership is to balancing the budget first and dealing with the resulting risks or safety second. The deliberately misleading but impressive language in this panel's terms of reference does not mask the fact that both CE Lin and TSH are overwhelmed by the urgency to balance their respective budget, and both are intent on cutting services, notwithstanding such are dependent upon by this community, and further, planning in a vacuum without any due regard to the Scarborough growing needs. If it meant ignoring the fiduciary duties to ensuring offloaded service are and will be met elsewhere in the neighborhood, as intended by the government, in the community close to home and at less cost, so be it. Numbers on the drawing board with no redneck trumps or else. The Hay report was commissioned with the sole intent and purpose of offering solutions to TSH budget constraints. That remains the sole reason for the past 2 external reviews and the present exercise. The Auditor General, on his 2011 report, questioned the cost-effective use of consultants by LHINs and hospitals, and critical of their failure to demonstrate accountability and value for money. For THX, this is the third external review on the same or similar issues in regards to its MNCC delivery program. The community objects to this desperate co-option, using consultants as a guise and means to validate and further TSH and CE-LIN's agenda. It's a waste of taxpayers' money. Take this as our notice to you. This is not acceptable. This ill-conceived plan would incapacitate the Scarborough Hospital in delivering safe health care and would lead to its eventual death by 1,000 cuts. We, the Scarborough community, deserve and demand safe health care. Thank you.
I'm a patient of Dr. Lam, and my name is Huang Wenhua.
She's a little bit nervous, and she wants me actually to read her what she wrote down. It's okay. Okay. So, I'm a patient of Dr. Tam. An accident happened when I had my third child. I had massive hemorrhage, and the floor was flooded with my blood. A faint glance at my baby was the only reward, and I was sent into ICU before losing consciousness. The only sound I could hear was when the hospital people called out to me to breathe. And all I recall is I was trying my best to keep breathing. Scarborough General Hospital has a team of very competent doctors and staff who spare no effort to work together to save lives. With adequate medical equipment in their hands, together with sufficient blood bank, my life was saved. The blood transfusion was vital in my case, and I almost had my own entire blood replaced. 3 days later, I finally woke up and started a new journey of my life, and I can't be more grateful to Dr. Tam and her team. His team. No words could express myself enough. I'm not the only one in my family that benefits from this hospital. Also, they prolonged my mother's life, and my mother is a diabetic. After 10 years of hemodialysis, 3 times a week, she passed away in March 2013. During her last 2 months, she went through angioplasty, had one leg amputated. I can still feel the suffering for her. And my mom was always ailing in my memory. This hospital tried every means and used a lot of resource to help her. She lived much longer than we expected thanks to the service provided by this hospital. I would like to appeal to any authorities on behalf of all pregnant women and all other patients in local Chinese community to keep Scarborough General